Good morning, good afternoon, good evening, and very warm welcome to everyone. Welcome to the second day of the International Pre-Conference on Primary Healthcare. Again, my name is Ludina Hailu, Primary Healthcare Advocacy and Partnership Lead at the International Institute for Primary Healthcare, Ethiopia, and I'm so excited to continue learning and collaborating with you all today. As a reminder, feel free to share your thoughts, stories, and questions with us in the chat and let us know where you are joining from. We are also keeping the conversation alive on social media. The main hashtag is #ICPHC, so we look forward to hearing from you there. Please browse the conference platform to learn more about the session and the speakers. Today, you can choose one of the concurrent sessions to attend immediately after this session by navigating to the main agenda page. I'll now give you an overview of what to expect from each session. The Political Economy of PhD Financing session will highlight how to effectively analyze and navigate both local and global political economies to better promote financing for PhD. For the session on the role of donors, we will discuss the impact, role, sustainability, motives, and benefits of donors and investors in PhD financing. The aim of the future of PhD financing is to explore the variety of possibilities for the future of PhD financing, given historical and present approaches, incorporating a forward-looking perspective, and reimagine what PhD financing can look like both in local and global contexts. Lastly, we will highlight the cost and value of integrated fragmented healthcare financing and how it can support PhD financing, with the intention to understand how fragmented PhD financing can impact continuity of patient care. You can earn ICPHC points each time you attend a session or participate in a discussion thread, and we will issue a prize for the most points earned while the pre-conference is taking place live. This meeting is being translated into French, and you can choose the language choice via the options on your screen. And just a friendly reminder to refer to the event's code of conduct posted in the chat to ensure respectful and inclusive participation for us all today. During today's discussion, we will review historical strategies, new sustainable approaches, and remaining challenges in PhD financing. Our moderator for this plenary session will be Dr. Matiko Riro, Regional Technical Advisor for Health Financing for Clinton Health Access Initiative. Based in Nairobi, Dr. Matiko is supporting a number of sub-Saharan African countries in health financing reform toward achieving universal health coverage. He has previously worked for several organizations as well as the government to drive innovations and initiatives geared towards health system strengthening. We look forward to engaging with you on the final day of the pre-conference. Thank you.
Hello, everyone. Welcome to today's session where we're going to have a deeper dive in health financing for PhD. Our plenary session today, we're looking at financing for PhD, including historical strategies, new approaches, and evidence, lingering gaps and challenges as well. So your moderator today, I'm Matiko Riro, a medical doctor and a health economist. I'm the Regional Technical Advisor for Health Financing at the Clinton Health Access Initiative, CHAI, and I'm based in Nairobi. In this role, I support several countries in driving health financing reforms towards achieving universal health coverage. We have a good set, a set of health financing experts that we will be having a conversation with this morning, and with various areas of expertise that will be quite helpful in terms of driving this conversation today. So my first speaker today is Professor Kara Hanson, who might, a number of you, Kara Hanson is no stranger. Kara is a professor of health systems economics and dean at the Faculty of Public Health and Policy at the London School of Hygiene and Tropical Medicine. Kara has spent the last 30 years researching the economics of health systems in low middle income countries. She chaired the recent Lancet Commission on Financing Primary Care and has authored key publications on how strategic purchasing can help improve health system performance. She has frequently advise national governments and international organizations on health system financing issues. And interestingly, she is currently just the president-elect of the International Health Economics Association. Welcome, Kara.
Thank you, Dr. Matiko, for that introduction, and thank you for the opportunity to join this pre-conference on PHC. Let me begin by sharing my screen. Super. So my remarks about financing primary healthcare draw very much on our recent Lancet Global Health Commission on financing primary healthcare that was developed with colleagues, commissioners who came from across the world, drawn from the worlds of research, the health system experience, and international agencies who deliberated for 18 months on what are the best ways to finance primary healthcare. I'll just begin with three stylized facts. The first is the very low level of government spending on primary healthcare in low and lower middle income countries. So you can see here that governments in low income countries spend on average $3 per capita on PHC, and in lower middle income countries only $16. And these amounts are very far away from the benchmark of any benchmark for what's needed to support access to a basic healthcare service package. The second is that out-of-pocket payments are the main source of PHC financing. So you see that individuals spend 4 times more than what governments spend. Much of this is on medicines, and it comes with all the risks of financial impoverishment and consequences for households. The third is that you get more if you spend more. So there's a positive relationship between government spending on PHC and the level of coverage. This is the UHC coverage index. So there's a positive relationship, but also at any given level of spending, there's a great variation in the level of achievement. So if you look at around the $5 mark, that countries achieve anywhere from 35 to over 70% UHC coverage. So it's not enough to spend more, it's important to spend better. We organized our work around these three main financing functions, where the money comes from, how it's pooled, how it's allocated to PHC and protected until it reaches those frontline providers, and then the way that PHC providers are paid, and all of this against a foundation of the political economy context. In terms of raising money for PHC, the most important things to remember are first that the amount of money that's available for PHC also depends on the success of the Ministry of Health in arguing for the health budget. The second is that that PHC is best funded through pooled public funds. So here we look alongside borrowing and aid at the critical importance of tax revenue and domestic resource mobilization as a way of ensuring sustained commitments to PHC. And the third is the importance of pooling, so that as governments develop their UHC financing schemes, it's important to cover PHC first, because PHC provides that foundation of health protection, and also households are often spending significant amounts of money out of pocket on PHC, as we've just seen. The second stage in this cycle is how resources are allocated to PHC. And here we explored the three main categories of policy levers for allocating money to PHC and for making sure that it actually is protected until it reaches first-line providers. And our report has lots of detail about these. I guess I would just draw particular attention to the role of provider payment in this budget execution path. So provider payment not only sets incentives, as I'll speak about in a moment, but it also is a means of earmarking a budget for PHC, particularly if it's based on capitation, and of making sure that those resources don't get drawn up into higher levels of the system. I think the service delivery part is also really important and will resonate with the conversations in this pre-conference about how important it is to have an operational definition of PHC, to set some norms and standards, to use referral and gatekeeping systems to protect those resources, but also to look for innovative delivery models which can provide a way of pulling resources out to the PHC level. We also argue that there are really good reasons to be shifting to a more strategic way of paying providers. So moving from a status quo of a budget or a fee-for-service system towards one that's a blended payment system that's built around capitation. And we chart a pathway towards that, and also think about what are some of the health system fundamentals that need it to be in place to support this system. Finally, we turned to the political economy of financing PHC, thinking about how the politics and the social conditions and the economic conditions of a country both provide some constraints to what's possible, but I think really importantly provide opportunities of thinking about what is a political window for really advocating for increased focus on PHC. We also argue that it's not enough to have clever technical strategies, that these technical strategies themselves need to be politically informed, and that requires understanding and navigating the political economy context and tracking it as it changes. So this is where we landed, that having people-centered primary healthcare also requires the financing arrangements to be people-centered. That means thinking about revenue mobilization and how to ensure there's adequate public funding for PHC, thinking about pooling and ensuring that pooled funds are used to cover PHC. On the resource allocation side, looking for equitable ways of allocating resources that are, where possible, that are needs adjusted, and for protecting those resources until they get to the frontline provider. And finally, to paying providers in a way that sets the right incentives and also that protects resources for PHC. So thinking about a blended system with capitation at its core. And finally, to make sure that all these technical decisions around the design of people-centered financing arrangements are informed by a really clear political strategy as well. Thank you very much.
Our next speaker is Dr. Angela Gishaga. Dr. Angela Gishaga is the CEO of the Financing Alliance for Health, where she serves ministries of health and finance globally in building resilient, sustainably financed primary and community health systems. A medical doctor with a master's in health economics and policy, Angela has served in the front lines in healthcare provision and leadership at the districts as well as the national level in driving financing, health financing and policy reforms. Angela has worked at McKinsey & Company's Africa Delivery Hub, working on socioeconomic issues, development issues in Africa. Angela has won several awards, including being named one of Fortune's World's Greatest Leaders in 2018. Angela serves on the global board of Population Services International, PSI, that operates in 46 countries globally.
In 1946, we had a clear direction on the definition of health, a comprehensive approach that ensured the highest attainable standard of care, but not just focused on the absence of disease. Despite gathering in Almaty in 1978 and again in Astana in 2018 to prioritize primary health, we still seem to see health through a disease-focused lens, defining who provides healthcare, that is the healthcare workers, defining where care should be sought, and most probably in health facilities, and also defining what state we need to be in to seek care, usually in very dire and diseased states. This approach is a challenge because the current disease of burden is largely preventable, yet we continue to invest in more costly curative care that a significant number of the population is not able to access. In addition, health is complex with many social determinants, but our care system is disease-geared, focusing on addressing symptoms rather than the root causes. Primary health care embodies a holistic approach to wellness. It advances preventive, promotive, curative, and rehabilitative care. It extends the continuum of care from brick and mortar health facilities into communities and into households. And it also empowers a diverse set of stakeholders to maintain health and wellness and does not leave this responsibility fully to a subset of few. The pandemic challenged an already strained healthcare system all across the globe. As we rebuild, let's focus our resources on improving resiliency of health systems, One, by applying a systems lens and focusing on strengthening platforms of delivery instead of disease siloed systems. Two, by integrating the services that we are delivering. Three, by extending the point of care to the point of need and not just the point of convenience. And four, by empowering communities to demand, co-deliver, and receive care. I look forward to the discussions on how we can reimagine and transform financing for primary healthcare. Let us learn together, challenge each other, and grow together. Thank you.
Our third speaker is Gina Lagomarsino. Gina is the president and the CEO of Results for Development, R4D, a nonprofit that works with change agents. That's both private sector and public sector players, as well as civil society leaders around the world to create strong systems that support healthy, educated individuals. Throughout her career, Ms. Lagomarsino has focused on expanding health coverage to low-income countries. As one of the original co-founders and managing directors at R4D, she helped galvanize energy and political will around global push for universal health coverage and led new thinking on how to build strong, mixed, that's private-public health systems. Ms. Lagomarsino has helped develop important initiatives that have helped advance universal health coverage across 20+ countries, including Primary Care Performance Initiative, the Center of Health Markets Innovations, and the Joint Learning Network for Universal Health Coverage. Prior to joining R4D, Gina spent a decade working to improve health systems in the United States as a senior health policy advisor to the DC Mayor, Anthony Williams, and at McKinsey & Company and Kaiser Permanente. She holds a master's degree in business administration from Harvard University and a bachelor's degree in public policy from Stanford University.
Hey everyone, I'm Gina Lagomarsino, the CEO of Results for Development, also known as R4D. I want to first thank the organizers of this event, including Her Excellency, Dr. Leah, for inviting me to be a part of this very distinguished panel of experts. At R4D, we're supporting many countries around the world to design and implement strong health systems. And in the process, we're working to document and share lessons learned about health financing for primary healthcare that leaders can adapt to their own contexts. I started my career working to create more equitable systems in the United States. So I've seen firsthand how poorly designed health financing can lead to inequalities and bad outcomes. But I've also had the opportunity to see how well-designed health financing can create a foundation for improving access and quality of primary healthcare. About 15 years ago, I was senior health policy advisor to the mayor of the District of Columbia, which is also known as Washington, DC. It's my family's home and also home to about 700,000 people, and a substantial portion of them are part of low-income and marginalized communities. So DC had an extremely inequitable health system. And I was involved in designing and implementing a reform that extended free coverage to people who didn't have it, and to ensure high access to high quality primary health care. The foundation of this reform was health financing. We repurposed $100 million in annual funds that had gone to a large hospital, and we used it in part to create a sustainable stream of funding that flows directly to primary healthcare clinics. This funding mechanism enabled us to assign patients to specific clinics to ensure they each had a clear primary healthcare center for coordinating their care. It also helped us get better data for decisions and to create incentives for improving quality. The result was that tens of thousands of people got health coverage who previously didn't have it, and the number of avoidable hospitalizations went down significantly due to better PHC. It's also led to much stronger primary healthcare providers who are more financially sustainable and more focused on improving quality. Of course, there is no one-size-fits-all approach, and what we did here in DC was specific to the context here. But the lesson I learned is that well-structured financing is the foundation of any strong primary healthcare system, and it makes other improvements possible. It also taught me that designing and implementing strong PHC reforms is complex operationally and politically. I'd now like to share 3 practical lessons based on our work at R4D, supporting countries such as Nigeria, Indonesia, Ghana, and our host country of Ethiopia. These lessons are informed by experience in these and many other countries around the world, including from the work in the Joint Learning Network for Universal Health Coverage, also known as the JLN, and the Strategic Purchasing Africa Resource Center, also known as the SPARC. These lessons also reflect the recommendations of the recent Lancet Commission on PHC. I want to thank my fellow panelist, Cara Hansen, for chairing that commission, and also my R4D colleague, Dr. Cheryl Cashin, who was also a commissioner. The first lesson I wanted to share is that strong PHC systems need to align financing and service delivery. Those of us who are focused on financing need to remember that the ultimate goal is to deliver high quality, accessible services. Financing is just there to enable that. The structure and capacity of the existing service delivery system should inform the structure of financing, and the goal should be to create financing that will support the delivery system and improve it. I think there's an interesting lesson learned from Ghana. About 10 years ago, leaders in Ghana attempted a new capitation-based health financing pilot designed to control costs and ensure access, but it didn't work very well because the service delivery system was not equipped to manage that type of financing. The good news is that Ghanaian leadership learned from the pilot and recognized that they needed to make adjustments to the service delivery system to enable strong financing. And they've been quite successful in doing that. They built on the investments they had made in community health to create primary healthcare networks of practice, which bring groups of providers together to close capacity and access gaps. And together, these groups are capable of delivering the full package of PHC and accepting population-based payments. And Ghanaian leaders have also ensured that government financing is well connected to these primary healthcare networks, and they're now rolling out the model across the country. The good news is that the model is enabling improvements in access and quality. I think this story underscores a second key lesson, and that is that successful health financing reforms usually involve some trial and error, and they typically require cross-agency collaboration. Rarely do countries get it perfect the first time. There are often unintended consequences. But if you can stay focused on continuous learning and improvement, over time, the system will improve. Often the nature of policy reforms means that a change in one part of the system necessitates a response in another part of the system. Multiple government agencies need to co-create and align with each other, and their roles need to be clearly defined and agreed upon. In the example I gave before, the Ghana National Health Insurance Authority started a financing reform, and the Ghana Health Service responded. And the two agencies collaborated and coordinated to get both parts of the system working well together over time. The third lesson I wanted to share is that health financing reforms require strong government leadership, with development partners playing supportive roles. At R4D, we know that we are most effective when we support the efforts of national and local leaders and align with their goals, their timelines, and their political processes. We can bring in evidence of what has worked elsewhere and even connect leaders with peers in other countries. And as a neutral partner, we can help to facilitate co-creation processes among government, academic, and private sector leaders. And we can support the strengthening of institutions to implement new policies, but we must stay in this supportive, facilitative role. A related point is that health financing reforms cannot be achieved through a time-bound donor project driven by outsiders. They won't get it right, and it won't be sustainable. So those of us who are funders and development partners need to make sure that our behaviors and our funding don't inhibit sustainable financing systems. I hope this set of lessons resonates with your experience. I am very eager to learn more lessons from all of you as this conversation continues. Thank you so much.
Our fourth speaker is Somto Chloe. Somto is a public health researcher, pharmacist who works on implementing high-impact projects towards strengthening health systems across West and Central Africa. She serves as African regional leader with the International Working Group for Health Systems Strengthening, and is a global shaper in World Economic Forum Global Shapers, a community of young people organizing for change across the world. She currently works with the public health team in Equivia, Middle East and Africa, contributing towards solving complex health challenges and improving equitable access to health in the region. Furthermore, Somto is committed to advocating for gender equality and championing youth caucuses in the region, in her community.
Thank you, Dr. Matiko, for that kind introduction. And I would love to thank the organizers of the International Pre-Conference on Primary Health Care for inviting me to share my perspective on this very distinguished panel. Very insightful hearing from all the brilliant speakers that we've had on this plenary. And I think it's important that we spotlight the importance of youth inclusion as we think through primary health care and the future of our continent. The reason for this is that Africa has the youngest population in the world. So over 70% of our population are under the age of 30. So with this huge population block presents a critical opportunity because young people are key agents for social change, for economic growth, for technological innovations, and even particularly in the sector of health. When we're thinking through strengthening primary health care and ultimately achieving universal health coverage, meaningful youth participation is key to this. Just like Professor Kara Hansen highlighted through the brilliant work done by the Lancet Commission on Health Financing, health government spending on primary health care is strongly associated with better service coverage. Young people have the power to demand strong political will from our leaders at all governance levels, from national to the smallest of subnational units, to boost spending on the health sector, to prioritize health in the annual budgets of countries, and really just to demand the kinds of change that we want to see in the primary healthcare sector. So for instance, we're in election cycles across many countries, and young people are starting to realize their voice as advocates to understand what is the percentage of the annual budget that is being prioritized towards health. So for me, first of all, that is the importance of young people in advocating for sustainable primary healthcare financing at all levels, really. At all levels. So just having that power to rally the support of the relevant government institutions, the stakeholders who matter, the private sector, and rallying towards private sector investments. And secondly, I'd like to talk about, very importantly, accountability, because we are uniquely positioned to hold our leaders accountable, particularly in the sector of primary health care, because that is the basic unit of care that everybody should be entitled to. We want to push our leaders to spend more and spend better on primary health care. We want to ensure that when commitments are gathered or when commitments are gotten from leaders across the board, that policies, that commitments do not just sit on shelves and gather dust at the National Ministry of Health offices, but actually we see implementation. We see that monies allocated to primary healthcare actually does end up being spent on primary healthcare. Ultimately, young people are the future of the health system. We are the ones who are going to face the consequences of the policies that are designed today.
As we get into our Q&A session, I wish to maybe throw questions to the panelists. I think they've had great conversation in terms of some of the, looking at some of the key issues that we can think about in PhD financing. And I wish to kick off the session, the question sessions with Dr. Angela Gishaga. So Angela, the Financing Alliance for Health has made significant contribution in terms of driving community-based approaches to strengthening health systems, but more so in terms of how all this can be applied, especially in driving resources that are available for to health. And of course, we know that as we drive resource mobilization, there's a call for efficiency, and therefore that calls me to ask you the first question: what would be your recommendation for improving PhD financing efficiency?
My name is Angela. Thank you for the opportunity to contribute to this conversation. Given that the burden of disease within the continent is largely preventable, investing in primary healthcare would advance well-being and communities to thrive. To promote efficiency in primary healthcare financing, we need to rebalance investments. We need to promote and recognize the continuum of primary healthcare. We need to integrate services, and we need to tap into different types and different sources of funding. In terms of rebalancing investments, we need to rebalance investments across curative care and preventive health services. We heavily invest in more costly curative care for advanced illnesses, where we could rebalance and invest more in preventive care and address illnesses even before they become complicated. Two, we need to recognize the continuum of care from the primary facility level to the household level and extend primary health services into the community. This will overcome the physical, financial, and social barriers to access to care, while also task sharing key interventions from more costly facility-based delivery to less costly community-based delivery. We need to integrate services and offer more holistic packages as opposed to fragmenting services along disease lines. Limited financial resources are better leveraged when strengthening all the pillars within an integrated system, as opposed to financing multiple parallel disease-focused systems that cause increased inefficiencies. We can actually get more quality, higher quality, and more health for the money we currently have in the system if it wasn't as fragmented and inefficient. And four, we need to increase and diversify the types and sources of funding that we tap into. Primary healthcare has a strong investment case. It has a strong social, a strong economic, and also a strong health investment case. With that investment case, there are roles and opportunities for investments beyond grants. Exploring private sector, blended finance, and debt conversion are viable avenues.
The second question for you, Angela, then even as you think about that background, then what do you think is the role of communities that could contribute to a well-sustained PHE financing?
Communities are resources to be tapped into as sources of valuable feedback on the quality of care provided, which is linked to the level and consistency of investment. As co-deliverers of care and services, community health workers are communities that form part of the human resources for health and ensure that there's a continuum of care to the household level. As co-investors through premiums paid into risk pooling mechanisms, that then will be able to meet the costs of primary healthcare services at the point of need. And communities are valuable resources as social accountability mechanisms to ensure resources are well spent as they are planned to be spent.
Thank you. So maybe I'll push to the next speaker, Gina Lagomarsino, just to, also based on the background that I think you've highlighted clearly some of the work that you have done with R4D and what R4D continues to do in terms of trying to, not only mobilize more resources, but also to enhance efficiencies in the allocation of the resources within the governments. So my question to you then is, what strategies will you recommend to increase the financial allocation for governments for PHE financing?
Thanks so much for that question about how to increase share of spending, of total health spending to primary health care. I think I'll leave it to the economists to give the technical answer about the different kinds of taxes that can be raised and how to actually shift allocations in financing systems, and maybe focus a little bit more on the practical side of this. I think it's all health financing decisions are inherently political. And one big challenge, I think, for primary healthcare is there's been such an underinvestment in primary healthcare over the years that people don't trust the system in their countries. And so therefore they tend to bypass the system. And it therefore is sometimes hard to generate political will to finance those primary health care systems more. So I think we need to address that and really figure out what are the kinds of interventions that are going to most strengthen primary care systems to build that trust and then therefore get more money flowing. And I think it's important to remember that the most important financing tool we have to actually improve care at the front lines is to make sure that funds can actually flow to facilities and that the people who lead those facilities have autonomy to manage the funds. And I think that, the more we can do that, the more we'll both improve the facilities performance and also build that political will we need to get more financing to PHC in the future.
Thank you, Gina. The second question to you then is, how do you propose to increase local capacity for well-sustained PHC financing?
So how to build capacity for health financing in countries at the national and local levels? It's a great question. I guess I can think of 3 ways. And one is that I think we need to continue to build individual skills and capacity, train more health economists who can be key decision makers in the system, but also people more at the front lines who have the right skills to be able to make funding allocation decisions and manage public financial systems. So that's number one, really continue to invest in that sort of training. I think, secondly, it's very important to build institutions that are capable of engaging effectively in health financing. And that means institutions with strong leadership and governance, with good ability to collect and use data for decision making, and with strong cultures that can actually continuously improve themselves over time and help a country or a subnational government on this long-term journey of improving health financing that will actually lead to better service delivery. And I guess a final way I think we can improve capacity is just by continuing to invest in learning across countries. And I know that's something we feel very strongly about at R4D. We're excited about the role we've been able to play alongside our partner AMREF in launching the SPARC, the Strategic Purchasing Africa Resource Center, and all of our partner institutions. I'm so excited about all of the new evidence and practical ideas that group of institutions and individuals has developed over the last several years that I think are building capacity across many countries and lessons learned for how to do financing better. So I hope we will continue to invest at all 3 of those levels.
So maybe I'll move to our, the next panelist with a couple of questions. I know, Kara, you've spent quite a significant chunk of your career in driving, policy conversations across the globe on financing care. And as you highlighted, key to some of the things that you've recently done is the Lancet Commission on PHC financing. And the quick question to you then is, what is the role of data in PHC financing?
So you've asked me, what is the role of data in PHC financing? So data is clearly critical. I'm going to focus here on health expenditure data. We're advocating for increased expenditure on PHC, but we can't track progress on that without a clear way of measuring it. And to do that, it's important to use a definition of PHC that's operationally useful in a country and that reflects the platform through which PHC is delivered. So tracking expenditure is important, and tracking expenditure is particularly challenging in decentralized contexts where resource allocation decisions are being made simultaneously by central authorities and by local authorities. I think that tracking these expenditure data is also really important to help to align the ambitions of a benefit package with fiscal capacity. So understanding, getting data on what resources are available from, for example, insurance contributions and then government subsidies alongside that, and then designing a benefit package that can be provided adequately within that envelope requires really strong sources of data.
Thank you, Kara. And maybe I can move to the next question for you. Then, what do you see, can be done to maximize the evidence base for PHC financing?
So we are in the enviable position of having a lot of evidence about what to do. So what are the characteristics or system design features that are needed to develop a financing system for PHC that ensures equity and efficiency and provides incentives for quality. And I just wanted to kind of call out the WHO Health Financing Progress Matrix. It's a great example of a set of normative guidance that's based on both rigorous research and on technical judgment. And our Lancet report is another source of such evidence. But I think we can do a lot more to generate evidence on how countries are actually implementing these arrangements. And to do this requires really strong partnerships between government and researchers. And these researchers need to be bringing a mindset of implementation research and expertise in policy analysis. And working together with government, there's evidence that can be generated that gives early signals about what's working, about where bottlenecks are being encountered, and then to help to generate evidence about where course correction is enabling and new ways of doing things are enabling more progress to be made. So an implementation research focus, and I think strong partnerships between governments and researchers are key.
Thank you, Kara. So, and to the next panelist, Somto Chloe. You know, as a youth leader, you with a significant contribution and engagement in communities, how can PHC systems and leaders best include and empower the youth to foster the improvement of PHC financing?
Thank you, Dr. Matiko, for that question that I believe is very, very important. How can primary healthcare systems and leaders best include and empower youth to foster the improvement of primary healthcare financing? So the needs of young people need to be taken into strong consideration when we're designing and thinking through strengthening our primary healthcare systems across our continent. And these are conversations, these are important decisions that do not just need to be made for youth, but also need to be made with youth. The needs of young people need to be taken into strong consideration. So for instance, when thinking through the basic package of minimum services being offered at the primary healthcare level, young people need to be part of that conversation. So I believe the first step to including and empowering youth to foster the improvement of primary healthcare financing is really just youth inclusion, youth engagement in design, in conceptualization. Secondly, I will talk about how important it is to communicate that this process is actually happening so that it's not just happening and there's no visibility, and just designing for youth and with youth, but also essentially publicizing that this is happening. This is publicizing at scale. So having these conversations in the mediums where young people gather and letting them know that, look, we are designing primary healthcare with you in mind. What we're doing with this design and communication process is that we're ensuring that young people have strong buy-in and a strong sense of ownership towards seeing primary healthcare work, an integral part of which is the financing of primary healthcare. Commitments that are made by ministries of health, commitments that are made by governments, commitments that are made by partners are widely disseminated, are widely publicized, and young people then know that young people then take a strong level of ownership and want to see it through. And this is where, you know, strong accountability mechanisms come into place in ensuring that certain commitments do not just remain commitments, but actually are seen through. So if policies are being created to ensure that human resources for health at the primary healthcare level are heavily incentivized, it means that we want to actually see that resource allocation happen transparently and happen the way it should. So yes, first the design, communication, accountability, and last, again, I will talk about advocacy, which I already highlighted before, because again, when we have that strong level of ownership, it means that these are some of the factors that are taken into decisions, even when it comes to electing leaders. These are some of the accountability and the advocacy mechanisms that including and empowering young people in primary healthcare will lead to. So it would be interesting to see the progress that is made, even just in inclusion of youth in primary healthcare, when we revisit some of these conversations, when the main international conference on primary healthcare is held. I believe it's going to be held next year. But yes, I would say those are my thoughts.
Thank you very much. So just to close this session, I would like maybe to ask a question and maybe seek a response from each of you. I know you've talked through a couple of very important points around how we can drive PHC financing. And the last question to you, and I wish to get a response from each of the panelists, is what are the key opportunities that you see for collaboration and coordination in order to optimize resources for PHC systems?
I think one of the key opportunities for collaboration and coordination is for PHC financing is between the Ministry of Finance and the Ministry of Health. So working together, really persuading ministries of finance of the value of investment in health and in primary health care in particular, but also working together in a collaborative way to optimize the ways in which resources flow through the system. So this involves working together to construct realistic budgets that are technically informed, to work together to identify the PFM bottlenecks that are impeding resources from flowing through the system and impeding them from getting to the front line, but also for aligning the complex funding flows that PHC providers face. So thinking about harmonizing and alignment if pooling itself isn't possible. And finally, I think finding innovative ways together to work alongside the budget to develop provider payment arrangements that give clearer signals to providers about how to deliver quality and efficiency and equity in the services that they deliver. So working with the Ministry of Finance in a collaborative and cooperative way throughout the financing system, I think has a lot of potential to improve PHC financing arrangements.
There are key opportunities for collaboration and coordination to optimize resources in primary healthcare based on level of investment, level of intervention, and common language. In terms of the level of investment, we need to identify models of care that are effective at a micro level and then explore pathways to scale through both the public and the private sector through partnerships. In terms of level of intervention, we need to leverage the convening and coordinating power of governments in country, as well as regional and global institutions. By exploring platforms that diverse stakeholders can be able to come together and share their work plans, that would be an opportunity to co-invest and align investments across key priorities within the country. And in terms of common language, how do we harmonize the language between the world of health and the world of finance? Translating health outcomes to economic and development impact will facilitate tapping into new and other expanding sources of financing for primary healthcare.
Thank you so much. It has been such an honor to be part of this amazing, amazing plenary. And really, my message has been very clear. It's really just the importance of youth inclusion as we think through strengthening primary health care across our entire continent. There's so much that we miss out on when young people are not part of this conversation, because we've seen constantly through sectors that young people are driving strong technological innovations in the continent. And we believe that we can contribute to solving some of these important health challenges, particularly in primary healthcare within our continent. Again, we want to be part of the design. We want to be part of conceptualizing primary healthcare. We want to be holding our leaders accountable, and we want to advocate for sustainable health financing. And so we want to advocate for sustainable health financing. And so, yes, my key messages include young people, because again, we are the future of the health system. Thank you.
I guess I'll leave this panel with one final thought about how we can better coordinate and collaborate to optimize resources for primary healthcare. And that is to remember that in the vast majority of countries around the world, most health financing is domestically generated and utilized. But there still are numerous programs that are led by development partners that are injecting funds into countries. And I think it's incredibly important to make sure there is alignment across those kinds of donor programs and domestic financing programs. And I think I need to put the onus on the donor community to ensure that what they do in the spirit of trying to improve primary health care or improve treatment for a particular disease or access to a particular drug or technology does not distort the health financing systems of the countries that they are working in, and actually ultimately have some negative unintended consequences. And again, thank you so much for inviting me to be a part of this esteemed panel. It's been fantastic.
So thank you very much. This has been a very wonderful session that you've had, and definitely looking forward to further conversations around PhD financing. A great team of panelists that have had a wide experience in PhD financing. Definitely a great group to continue having a conversation with. Thank you.
Hello everyone. As this is the final plenary session for the pre-conference, our planning committee would like to thank all of our moderators and speakers for your impactful contribution to this conference and to primary healthcare as a whole through the important work that you do. We would also like to thank our sponsor, the Bill and Melinda Gates Foundation, for their generosity in funding this event. To our collaborators, the Ministry of Health, Johns Hopkins Bloomberg School of Public Health, and Center for Communication Programs, Clinton Health Access Initiative, and PATH. Thank you so much for your unwavering support in execution of the pre-conference. Lastly, thank you so much to all of you for your wonderful participation, for making this event a successful step forward to advance primary healthcare. Although this pre-conference is coming to an end, this doesn't mean that this conversation needs to stop here. Please continue your participation in one of our concurrent sessions. For more networking opportunities on a digital platform, we encourage you all to join the Community of Practice, a collaboration between ICPHC and Last Mile Health aimed to connect PHC leaders and practitioners to advance strong, flexible, proactive community-based healthcare systems. As a reminder, this is a pre-conference, so we hope to see you all at our main international conference on primary healthcare that will occur in a hybrid format in September 2023. Thank you all again. Looking forward to seeing you next year.